Good afternoon and welcome to the DCRI Noon Research Conference. It's my pleasure to introduce our speakers for today, Catherine Flynn and Kevin Weinfurt. Catherine is an assistant professor in the Department of Psychiatry and Behavioral Sciences at Duke University. She received her BA, MS, and PhD from University of Wisconsin in Madison in Population Health Sciences, and then came to the Duke Clinical Research Institute to perform a postdoctoral fellowship before joining the faculty. Kevin Weinfurt is an associate professor in the Department of Psychiatry and Behavioral Sciences here at Duke University. He's also an associate professor in the Department of Psychology and Neurosciences at Duke University. He completed his PhD in cognitive psychology at Georgetown University before coming to Duke and assuming his current position as Deputy Director in the Center for Clinical and Genetic Economics. Catherine and Kevin will discuss improving the measurement of patient-related outcomes and some subtitles that I'm sure they'll get into in a moment. Thank you for coming.
Thank you very much, Rick. Am I on? Okay. I have a cold. My ears are very blocked, and I tend to shout when I get excited during presentations anyway, so everyone feel free to do this because there's no real feedback happening here. Well, you know, I gave a research conference a few years ago, and the title was Psychological and Philosophical Perspectives on Informed Consent in Phase 1 Trials, and hardly anyone showed up. I don't know why. So we put sex into the title of this one, and still are a great deal of people here. So next time we're going to make it even more lewd. Okay, well, good to see everyone. What we're going to do is I'm going to give a little overview about an NIH network that we're a part of, and tell you a little bit about the resources of that network, because people here at Duke are already using some of those resources, and I want to let you know about them. And then Catherine is going to take over and discuss some of our specific work within this network, developing a measure of sexual function. Not necessarily to go into detail about the measure, but to give you an idea of the kind of work that goes on in this when we develop patient-reported outcome measures. So just stepping way back, I mean, the main question that most motivated this network, as it did everything else, is what are the effects of diseases and their treatments? We have to ask them, well, how do we conceptualize effects? What do we mean by effects? Certainly we can look at sort of biological, physiological endpoints, but as everyone here I know appreciates, there are other things as well. And in an influential model published in JAMA in '95, Wilson and Cleary outline some of these other things that are important to understand the effects of diseases and their treatments on people's daily lives. So we've got symptom status, functional status, people's general health perceptions. So these are important to understand to make informed medical decisions, right? Now, with no disrespect to the clinicians in the room, a lot of research has shown that as we move to the right in this figure, clinician reports are often less accurate than just talking to the patient themselves, right? And so the patient's perspective is key, and the goal is to try to systematically assess this perspective. And that effort to systematically assess it is known as patient-reported outcome measurement, or I'm going to say PRO for patient-reported outcome. And PROs are used in clinical research, which in turn informs clinical care. And there's also a lot of interest these days in using patient-reported outcome measurement specifically in clinical care to help with symptom monitoring and management. And you may, those of you who know Amy Abernathy might know that Duke has one of the most developed patient-reported outcome measurement systems in clinical care over at the Cancer Center. And my buddy Bryce Reeve from Chapel Hill is going to be doing a later research conference, I think maybe in March, talking about some other ways that patient-reported measurement is being used to assess safety. So very interesting. Okay. So it's great to get the systematic measures of people's experiences, but there are several challenges to doing so, and these challenges were identified by NIH a while ago. And these included, there are a lot of measures of the same health concept. Right? So if you're a researcher wanting to assess physical functioning, for example, if you go into the literature, you've got to spend quite a lot of time sifting through all sorts of measures, and you've got to assess their quality, and their quality varies quite a bit. So it's not like just because something is published means it's a good measure. There's some really highly interesting measures published, as we found when we have to review these. Because there are many different measures, it's difficult to compare results of research, both across studies and within condition. Right? So some standardization would be helpful. A lot of the measures are complex. They've got all these skip patterns and everything. And a lot of them, especially the ones that came from more of a psychology background, are very long, because we psychologists like to just obsess. And so based on these observed challenges, NIH put out a call for grants, and they described the product they wanted here. The clinical outcomes research enterprise would be enhanced greatly by the availability of a psychometrically validated, that's a fancy word for statistics, dynamic system to measure patient-reported outcomes efficiently in study participants with a wide range of chronic diseases and demographic characteristics. And anyone who's worked on a mission statement or vision exercise will realize that probably took them 8 days and lots of snacks to put that statement together. But they did, and they put out an RFA for the PROMIS network. And so the PROMIS network consists of, right now, 12 different sites and 3 network centers and NIH. This is a network, cooperative network with NIH. So PROMIS is 3 things, basically. First of all, PROMIS is a set of measures. And right now there are measures of patient-reported outcomes for adults, 22 of them. And those include physical functioning and anxiety, depression. We'll get into those. We're going to get into a lot of anxiety and depression in this talk later. 8 measures for pediatric populations. And these measures were developed using sort of the state of the science in measure development. And that's the second thing that PROMIS is a body of science. PROMIS is trying to really push the envelope in the developmental aspects of measures. So, for example, there's this literature in education testing. If anyone's had to take some licensing exam, you've taken it at a computer, or you've taken the GREs, you've most likely have enjoyed the benefits of item response theory. It's a statistical model in education research, and people in health research are now taking that model and applying it to see how could we measure patients' health status better. So PROMIS is really trying to figure out the best way to implement that, and PROMIS is based on this approach, which we'll say a little bit more about. And then finally, PROMIS is also software to disseminate and administer these new measures that have been developed, and the software is free for use. Okay, just a quick overview of PROMIS. PROMIS began in 2005. There was an initial 5-year grant, and the activities there were to create the measures, create the software, which is called Assessment Center, and then conduct some validity testing of those measures in specific clinical populations. That was such a big hit that we were all very happy that they came up with 4 more years of funding for PROMIS, starting in 2010. We just call that PROMIS 2. And whereas there were 6 sites in PROMIS 1, there are 12 sites in PROMIS 2. And the chief activities are to develop measures of new concepts that have not yet had measures developed, and to do additional validity testing. Okay. So today, as we look at what progress has occurred, I'm just going to give you some idea of some of the uptake of this. Keeping in mind the project is not done. Clinical researchers are arguably the primary audience of this work. And so the question arises, well, are people interested in the PROMIS? Are they checking into it? Well, you can only look at the measures by registering on Assessment Center, the PROMIS software. And over 2,600 people from 45 different countries have registered on Assessment Center to look at the measures. So that's pretty good. People are at least curious. It's also nice if people actually start using the measures. And while we can't keep track of every time someone uses a measure, we do know who is running studies using the PROMIS software and PROMIS measures. And so in 2010, there were over 8,000 study participants assessed using PROMIS measures. That doesn't include the thousands of patients we've collected data on as PROMIS investigators. Okay? So these are non-PROMIS folks. These are outside folks who are interested in running studies in PROMIS. And since the software went live in 2007, there have been over 18,000 participants assessed. Okay. These measures were designed to improve clinical research, but it's also been kind of cool to see how PROMIS has gone beyond clinical research settings. And a couple ways that PROMIS is contributing that we didn't quite expect are as follows. The first is, I think everybody here knows about the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, which lists all the diagnostic criteria for mental disorders. And we're currently on DSM-4R, text revision, and they are working on DSM-5 to come out in 2013. And as part of this, they try to make this diagnostic criteria as empirically couth as possible, so they conduct field studies to check out the structure of these diagnostic categories. And we're very, very happy that the DSM-5 field trials are using PROMIS to assess emotional distress. That's pretty nice. Another kind of unexpected application of PROMIS outside of clinical research has to do with population health monitoring. Specifically, the National Health Interview Survey is using PROMIS in its cancer module. The RAND American Life Panel is using PROMIS. And Healthy People 2020 has selected PROMIS measures to use over the next decade. I'll also add to this that those of you who are familiar with the Murdoch study may be interested to know that we have PROMIS measures in the Murdoch study. So we'll have longitudinal PROMIS data coming out of that study. It's very, very cool. Okay, so there are four kind of values that PROMIS has been going for, and I'll just describe them briefly here. The first is comparability. Again, because there were so many measures out there, it made life difficult. So if you had a chemotherapy trial, an osteoarthritis trial, and a heart failure trial, it's difficult to talk about the burden of disease across these. So one of the things PROMIS is seeking to do is to generate measures that are comparable across conditions and across types of studies within condition. The second value is sort of the classic value for measures, reliability and validity. And in terms of an archer, reliability means that all the arrows hit the same spot, and validity means that spot is the bullseye. Right? And so PROMIS has been trying to achieve high reliability and high validity. Third, flexibility. Clinical researchers are now collecting data in all sorts of contexts, using all sorts of modes of administration. And so PROMIS has done work to try to implement PROMIS measures in different modes of administration. And PROMIS has conducted probably the best study ever done on whether the mode of administration makes a difference in the measures. Right? You get the same answer if someone does it on a PDA or a computer or an interactive voice response on your phone. The answer is no, but I won't go into that in detail. But, and the fourth value was inclusiveness, that the measures need to be relevant for everyone, no matter the age, culture, or whether the person has some special needs that require assistive technologies. Okay? So these are the 4 measurement goals of PROMIS. So I want to introduce 2 technical terms so that we're all able to discuss the rest of the talk reasonably well. Domain and item bank. So when we say a domain, what we mean is the specific feeling, function, or perception you want to measure. Okay? So let's go through some examples. Specific feeling, like fatigue or pain or anxiety. These are feelings people have. Right? Specific functions like physical function, erectile function, how well people are able to do some things. And perceptions, how does a person perceive or think about something, like what's their satisfaction with their degree of social participation, or what's their impression of their general health. Some of you might know that the single item in the SF-36, just rate your general health, is probably one of the best predictors of mortality independent of all the clinical data. It's very, very interesting. So those perceptions are valuable to measure. Another thing about a domain is that it cuts across diseases, so that we can say we're studying fatigue as it occurs in osteoarthritis, as it occurs in people getting chemotherapy. Okay? So PROMIS has defined these in an effort to try to make it consistent across conditions. Okay? And so we've got some adult domains that we have measures for and pediatric domains. The adult domains include physical function, fatigue, pain, sleep, depression, anxiety, anger, satisfaction with social participation, sexual function, psychosocial illness impact, and applied cognition. The pediatrics are physical function, pain, fatigue, depression, anxiety, anger, peer relationships, and asthma-specific symptoms. Right? And there are 6 other domains under development. Pediatrics is one of the areas of great emphasis in the second round of PROMIS. 4 of the 12 sites are focusing on pediatrics. Okay, so those are domains. This is what we're trying to measure. The way that we go about measuring almost all the domains is by creating an item bank. And so an item bank is not a set of questions that you put together. You call it the Weinfurt Mountain Dew Anxiety Scale, and you put it on the shelf there. And anyone who wants to use it uses these 16 items. Okay? Something different. An item bank is it's a large collection of items that are measuring a single domain. So it's just a collection of items, kind of like a library of items. Any and all of the items could be used to provide a score for that domain. So you can select whichever items you want from there. Makes it very flexible. So let me give you an example. So physical function. We observe out in the world that people vary in their degree of physical function. We like to systematically assess this somehow so we can use this information in studies. And so we'll construct a physical function item bank. And that item bank is going to have a whole bunch of questions in it. The font's a little bit small here, but those questions have a range. So, for example, are you able to get in and out of bed is at the low end here. Right? Are you able to run 5 miles is at the high end. Are you able to get in and out of bed would provide information about kind of where you are in physical functioning toward the lower end. Right? If a guy comes in and just sprinted into your clinic visit wearing jogging shoes and he broke a sweat and he looks like he's about to go run the rest of the marathon, it would be a waste of your time to be asking the guy if he has trouble getting in and out of a chair. Similarly, when we design a measure, we'd like to design it in such a way that you're only asking questions that make sense for this person. So it's great to be able to index kind of where along the severity of physical functioning do all these items fall. Okay? And again, let me just stress, this is not an off-the-shelf set of items. It's a collection, and it's dynamic. So that is, once the PROMIS physical function item bank is created, it doesn't just stay there. It evolves through this cycle of development and validation and can be modified. And Catherine's going to go through a little bit of the work that we do to do that. So let me give some background before I introduce Catherine. This, by the way, the male is a faculty member here at the DCRI. I won't tell you which one. You can guess. So Catherine and I are not sex researchers. We should just say that out front. We got the PROMIS grant because we developed patient-reported outcome measures. After we got the grant, the National Cancer Institute said, this is a great infrastructure, PROMIS. Let's give supplements to people to develop measures that our cancer researchers are telling us they need better measures of. Don't try to diagram that sentence. I don't know how it went. And so NCI identified 4 areas that they wanted measures for, and we were assigned the bedroom ones, sleep and sex. We were assigned these. And so we did our best, and our best was actually pretty good because it became the basis for our PROMIS 2 application, and we were picked again to be in PROMIS with an all-sex project. Before it was kind of a mix, but we just committed ourselves entirely to sex now. And so, but really, we like to illustrate for you some of the kinds of work that go into developing and validating a measure like this. And so Catherine, who knows a lot more about this than I do, is going to take over for us here. There you are. Turn yourself on.
Not like that, though. I didn't say that before the mic went up. So. Okay.
There you are.
Great. Thank you. All right. All right, so just to give you an outline of what I'll be talking to you about, first just to give you some idea of the motivation for this measure, and then I'll go through some of the qualitative development work that we've done, and then some psychometric results and a demonstration of the measure in action, and then finally one of the validity studies that we've done on a diary study. So to start with the motivation, for starters, the National Cancer Institute thought this domain was important enough to fund the development of this measure and assign it to us. And I'll give you a couple of examples of things we heard from patients on this topic. The first is that a disease like cancer, as well as other chronic diseases, can harm intimacy. So we had a woman in one of our focus groups who had cancer who said, I've got this cancer in me, why would anyone want to sleep with me? Second, in a group of men with heart failure and diabetes, we also heard a similar type of thing. These are often men who have problems with erectile function, and one of them said, I felt like my manhood was being ripped away from me. To me, it was like, if I lose my sex life, I might as well die. Another man in the same group had a similar feeling. He said, some days I don't want to live. Over sex, I had to redefine myself. And in fact, all of the men in this group had actually stopped taking their medications at some point, especially medications for high blood pressure, in an effort to regain that erectile function that they were so distressed about losing. So those are a couple examples. So this is obviously an important domain because when things aren't going well for people, it can be harmful to their sense of self and their intimate relationships. But it's also important because when things are going well in this area of life, it can actually promote people's sense of health and well-being. We heard from another woman with cancer who said, for me, I think part of going through the diagnosis and the treatment is you want to reaffirm everything that you can do. You're acutely aware of what you can't do or the compromises to your other functions because of the chemo. So for me, sex was like an affirmation that I was still normal in other regards. So because the domain is important to patients, there is interest in including sexual outcomes in intervention trials. But unfortunately, a lot of the existing measures were quite limited. And we did a comprehensive review of existing measures. Because it was funded initially by the NCI, we started this review just in cancer populations. And so our first look at this, we published in Cancer in 2009. And there have actually been some more recent measures that are promising, but the main need for better measures still exists. So the things that we're especially interested in improving in this measure are creating a measure that's comprehensive. So we want to represent both physical as well as psychosocial dimensions of sexual function. We want a measure that's flexible. So Kevin talked a little bit about this in terms of the mode of administration, but we also, in this particular domain, because it is a very, it has a lot of facets to it, we want a measure that allows researchers to include only those facets of the domain that they are particularly interested in or that are relevant to their work. We want a measure that's sensitive, so at the least, we don't want it to be offensive to people. And related to that, we want a measure that's broadly applicable with respect to a lot of different aspects, such as age, gender, sexual orientation, whether or not someone has a partner, and then literacy level as well. And then finally, the ideal measure would also address disease symptoms that can interfere with functioning. So our measure development process followed the PROMIS process, which includes extensive qualitative development and then item bank development based on item response theory. And so I'll be going over each of these in a little more detail, but I wanted to start just with a brief summary to give you a sense of the full process. So we started with identifying existing items. Just within cancer, there were over 1,100 that we looked through, and actually since then, as part of PROMIS 2, we've looked through probably another 1,000 items. We then, within those items, a lot of them have overlapping content, and so we classify like items together and then select from those like items which items we think are the best, and winnow those 1,100 items down to less than 50 items. Concurrent with that, we do a lot of qualitative work, which starts with patient focus groups. We've done, at this point, 23 focus groups with patients, and those were in 4 disease areas. We also have had formal discussions with clinicians in those same disease areas, and those are cancer, heart failure, diabetes, and mood and anxiety disorders. We've also written a lot of new items ourselves, and after we have selected and revised items from existing measures and written new items, we then take those items and go over question by question or item by item with patients to make sure that their understanding of the items is what we intend, and those are called cognitive interviews. And so we've done 40 of those so far, and we have another 50 planned for this spring. We've had another number of experts review the measure as a whole, and we ended up with our first version of the measure with about 87 items, and those were given to over 780 people who filled them out, and then we do some statistical analysis on those items. And then finally, as I mentioned, we have an additional validation study in our diary study where we're evaluating the part of the question that says in the past 30 days. So that's our recall period for our sexual function questions, and so we evaluated that formally in 200 participants. Okay, so now I'm going to give you a little bit more detail about the qualitative development work. So this started with our focus groups. We've done 23 so far, but 16 of those were with patients with cancer. Some of them were with people who were actually undergoing treatment for their cancer at that time, and others of the groups were with people who were finished with treatment and were in the survivorship phase. So this work was published in Psycho-Oncology, and the goal of the focus groups is first to establish the importance of the domain for patients, as I gave you some of those quotes earlier, and second, to establish the scope of the domain. So what particular parts of people's lives do they include, when they think about their sex life or their sexual function, what are they including in that definition? And this really helped us to clarify our conceptual model of what we want to measure, and so where we need to have questions. And then finally, these groups led directly to the identification of those symptoms that people felt interfered with their sex lives. So just to go briefly over the focus group themes, we heard about changes people had experienced in their sexual response. So those bodily changes, such as erectile function. We also heard a lot about changes in intimacy, so not necessarily bodily changes, but changes to their intimate relationships and also how they feel about themselves. And then we heard about those specific interfering factors. So these We heard about physical factors like fatigue or shortness of breath or pain. We heard about mood-related factors like anger or depression that affect people's sexual function. And then we heard specifically about some treatment-related things, specifically in cancer, hair loss or weight gain related to chemotherapy that really affected people's sex lives. So after getting sort of the content through the focus groups and developing the questions themselves, as I mentioned, we then sit down and go through question by question with patients to make sure that they understand the items. And so these are called cognitive interviews. The goal of the cognitive interviews are to assess 4 things. So the first thing is to assess understanding. So here we want to know, specific terms within the question as a whole. How do people understand this question? And are they understanding it the way we mean to? And PROMIS really is very rigorous on this point, especially because they prescribe that you have at least 5 people who look at every single item that you are considering, and at least 2 of those people need to have less than a 9th grade reading level. And especially in this domain where there are lots of different terms for things and a lot of nuance, it was really important to establish that anyone could understand our questions and answer them. The second point that you want to assess in a cognitive interview is whether your question is making any assumptions that you don't mean for it to make. So a lot of existing items, the way they were worded, assumed that you were participating in a particular sexual activity that not everyone might participate in. And so we wanted to remove all of that from our items so that they could be more applicable to more people. Third is response. So when you see a question on a survey and you answer that question in your head, you have what that true answer is. You then need to, of course, map that onto one of the 5 options that are presented for you in the survey. And so what we're doing here is formally assessing whether those response options that we're providing are going to capture people's true answers. And then finally, the recall period. So while a lot of the PROMIS measures use a 7-day recall period, they may ask, in the past 7 days, how fatigued have you felt? In our qualitative work and the focus groups, especially in the cognitive interviews, people described to us that really 7 days is not perhaps long enough to have enough opportunity to have sexual activity to report on, and so we felt that a 1-month recall period was better for this particular domain. So we just went over the qualitative work, where we were talking to patients directly about what content is important to them, making sure they understand the questions as we worded them. And we then administered those items to the 780 people, and we did some statistical analyses to help us decide which items work and should be included in the measure. And so we call those statistical analyses psychometrics. And I'll describe that briefly to you now. So I'm going to use the example of our item bank on satisfaction with sex life. So as Kevin presented to you with physical function, here too there's a range of satisfaction in the population. And so in this case, the item bank that we are developing is a collection of items that all measure satisfaction with sex life. So then using item response theory, we can understand where along the range of satisfaction each item is providing the most information. So I've listed up for you four of our items here. So in other analyses, we've already established that we have a need to measure satisfaction with sex life. And so we are intending for each of these individual items to measure that concept to some extent. And so I'm going to demonstrate for you now one particular statistical analysis that we look at to help us evaluate each individual item. So here's the item. When you've had sexual activity, how satisfying has it been? And what we can see here in this information curve is that this is really a great item for measuring the domain of satisfaction with sex life. This is what we're looking for in an item because, first of all, it has a large range. Okay, so this means the fact that it's wide along the bottom means that it's sensitive to people going from low satisfaction to high satisfaction. And second, it's peaked. So wherever you see the peaks, that means that this item is supplying precise information, and in this case, those peaks extend across most of the range of the item. So you can compare this relatively good item, this is really what we're looking for, to an item like this. This is, how often have you wished that your sex life was better? This is not a good item for measuring the domain of satisfaction with sex life. It is basically supplying us no reliable information about satisfaction for anyone. There are no peaks across the entire range. And so this is an item that we ended up dropping. It did fine in our qualitative work, the cognitive interviews. People had no problem understanding it, but it's not providing us any information about the concept that we're interested in, and so we dropped it. And now here is an example of an item that in qualitative work, people were really adamant about this being important. So this item reads, how satisfied have you been with your ability to share warmth and intimacy with another person? So people really felt strongly that satisfaction with sex life is not just about how your body functions, but that your ability to be intimate with someone and to share that with someone is a really important part to satisfaction. But however, if you look at the item information that we're getting, it's not peaked anywhere really. It gets up to about 1 at the lower end, but it's not a very high peak. And so it really raises the question for us as to whether we should ask this. You know, you have very limited space in a survey of which questions you want to include, and so even though this was really important to people, it's not clear that it's providing us with useful information. And so one of the things that we are charged with then is sort of squaring the qualitative and the quantitative information to try to best understand and best measure the patient experience. Okay, so now I'm going to show you the measure in action. In addition to asking people about their sexual function, we also ask the question, have you ever asked an oncology doctor or nurse about problems with your sex life? And the reason we ask that is because we thought that asking for help or asking for a change in treatment might be a good indication of a clinically meaningful decline for someone. And so we wanted to approximate that. And so I'll show you the results here. So I'm going to show you the results for 5 of our subdomains within sexual function. So those are listed across the top. These are specific areas within sexual function. And what we see are I'll show you large differences between people who asked and people who didn't. And they're in the directions that we would expect, which is a great for us to know that our measure is functioning the way we intend it. So what you'll see is on the right side are people who did ask, and on the left side are people who didn't ask. So for example, with interest, people who had more interest in sexual activity were more likely to have asked about problems with their sex life. People who had less erectile function or lower erectile function were more likely to have asked, as we would expect, because they have problems, and so they asked. Likewise, women with less lubrication were more likely to have asked about problems with their sex life. Women with more vaginal discomfort were more likely to have asked. And then finally, people with more satisfaction were less likely to have asked. And in fact, these effects are actually underestimates because some people who may have asked, we hope, actually got help and then improved. Okay, so finally, I'm going to show you some results from our diary study. So this study was designed to formally test that 30-day recall period. And so we designed a study where we would have people we collected all of it through Assessment Center, the software program that Kevin mentioned earlier. And then we followed up with email and telephone calls if people missed any of their daily assessments. So basically what we did is we had them first complete a baseline assessment using that 30-day recall period, asking them all of our sexual function questions. Then every day for 30 days, they completed a short questionnaire where they were asked in the past 24 hours. They were asked about interest, and if they had sexual activity, they were asked about their sexual function and their satisfaction. And then at the end of 30 days, we had a final assessment where we again asked over 30 days, we asked them to recall back over those 30 days and tell us about their interests, their sexual function, and their satisfaction. And at that final assessment, we also included the positive and negative affect scale, to assess their mood when they were completing that final assessment. So I'm going to show you two results. The first is about the item that asks people their ability to have a satisfying orgasm. So across the bottom is basically the real true answer. So this is their average daily response. So this is when they're only recalling over the event that just happened within the past 24 hours. And then on the y-axis, we have their recalled answer. So this is the answer they gave us at the end of the month. And if there was a perfect recollection, the line that you would see, the correlation between these two, would be that dotted line there. However, you can be wrong in two ways. So the first is if your line is above that dotted line, and this is if you're recalling things as being better than they actually were. And the other way you could be wrong is if you recall things as being worse than they actually were. And that would be if we see the line down under that yellow dotted line. And we're going to look at three lines, and these are people who were in a good mood. They had 1.5 standard deviations above the mean for positive affect, as well as people who had the average positive affect, and people who were a little sad that day, 1.5 standard deviations below. So this is people who were in a good mood. They are recalling things as way better than they actually were. So people who, on average, had a 1, they were unable, basically, to have a satisfying orgasm. Over the month, they're recalling they had a 3, which is pretty good, right in the middle. And people with the mean did a little better. So these are people who have the average positive mood. And then people who were not feeling so great that day actually are pretty close to what we would hope to see in terms of recall. So there's clearly some issue, at least with this item, as to whether people are really able to accurately recall their ability to have a satisfying orgasm. And I'll say the two examples I've pulled out for you are the two where we saw effects. And actually, for most of the items in the measure, there weren't any effects like this, which is great because we are then more confident in using that 30-day recall period and not saying you have to ask people every day if you want an accurate answer. Okay, so here's the other item I'll show you, which is asking, this is just now in men, your ability to get and keep an erection. Okay, we have the same setup here. Does anyone want to guess? Men in a good mood, their ability to remember over the past month, their ability to get and keep an erection? All right, well, here it is. Okay, so really bad at being able to remember, or they're really feeling great about themselves. So, this is even men who, on average, had a 1. So that they are unable to get and keep an erection. When they recall over 30 days, they're giving themselves a 4, which is almost the top category. And people who are, average in terms of positive affect, a little better, although still almost a full point higher at the low end. And then almost exact. People who are sad remember almost exactly right. So. What's also interesting about this is we ask individual items that follow up right after this item about specifically getting an erection and keeping an erection. And those individual items don't show these same effects. And so there's something about this sort of global evaluation of erectile function that is particularly susceptible to mood effects. So then just to give you a couple ideas of where we're going next with this. The first version is now available on Assessment Center. You can administer it to people and put it in your surveys. We are now currently extending the development to other chronic diseases, so we're in the midst of extending it from just cancer populations to heart failure, diabetes, and mood and anxiety disorders. We are also going to be testing the measure in a U.S. representative population to provide some norms to use in scoring. And then we hope to also be doing some work with translation. thank you very much. I think Kevin and I will be available for questions now.
Maybe before we do questions, could we just say to include in your applause the folks in our group who have worked on PROMIS in no particular order. Carrie Dombeck. I'm sorry, I'm so stoned on cold medication here. Maria Fawzi, and Felicia Graham, and Lee Lin. Am I missing anyone else?
No,
I think that's it. Okay.
Good.
Here we go.
I'm sure people have questions and comments. As you're thinking, I'll ask two. One is I noticed that PROMIS is registered. So who owns the rights to that software? That's a very practical question. The second is, what do you do with the information? You make assessments, just like Catherine, you walked us through. So how would patients in the cancer center, as an example, benefit from the kind of information that you've derived from this particular work?
So actually, the intellectual property question has been a significant one for the PROMIS network because NIH holds the trademark on the name PROMIS. A separate organization called the PROMIS Health Organization, made up only of investigators, holds the IP on the measures themselves, and Northwestern holds the IP on the software. And now we're working on a sustainability plan going forward. So very interesting. And to the second question, what they're doing at the cancer center is they're not using PROMIS items for a lot of their stuff. They've got just basically a list of single items corresponding to single symptoms, and patients just fill those out before they're all on, I think, a 10-point scale or 9-point scale, and the software just flags any one that's over a 7, I think, 7 or over, and the doc just gets that when the patient comes in.
And hopefully an intervention. It's not something where they say, gee, that's really interesting.
Yes.
So there's something in place where an intervention would take place if the score is in a certain range.
Yeah, and interestingly, Amy found with her data, she's got a single question about sex, and they have discovered there that a lot of their patients who are on interferon all have sex issues, and they weren't aware of that because no one was asking the patients. But that's one thing that has allowed the clinic to kind of learn from analyzing these data.
One observation, Amy, in a practical sense of dealing with lots and lots of patients, can ask one question and you've got 87 items. That's a bit of a disconnect. The other piece is this looks like what in IT they call an ASP model, where you have to go and use the software that's at Northwestern to do the questionnaire and to get the scoring back. Is that correct?
No.
Then how do they know how many administrations have been done?
Well, so question one. So when we say we've got 87 items, these are sprinkled across how many? 11 different subdomains. So we actually have some subdomains that only have 4 items. So we have a brief profile of sexual function that has
8,
about 8, depending upon male or female items. The nice thing is that if you start out with, say, 20 items in an item bank, and you really understand the concept well and understand the different severities and all that, you can go in and say, for the American Life Panel, for example, we've only got space for 1 physical function item. And so you can say, well, tell me about your population. And I can go into our item bank and see what item seems to cover the areas of functioning well for this population and what provides the most information there using those kind of curves Catherine was showing. And that could be your single item measure, but you can choose that single item much more intelligently when you're drawing it from an item bank. And then the other really cool thing is that Doc might be running a study where he's got a single item of physical function in his study, and Sherry Janin uses the PROMIS physical function in a different study with class 4 heart failure patients, and has a very different single item, sensitive to people with really low physical functioning, and you get scores on the same metric there. So there's comparability there. So I think that answers it. The second question about availability. Right now, if you want to look at the items, you've got to go to Assessment Center or ask a friend who's been to Assessment Center and downloaded some PDFs or something. But it's free to do. But they're doing that in part to try to keep track of how many people are looking, because it's a useful metric to try to get more money out of NIH, right? To actually administer the measures, you could administer them as paper and pencil. If you want to do computerized adaptive testing, where it gives you a question that, depending upon your answer, it goes in the item bank and selects the next item that's going to be the most informative, that you don't have to use Assessment Center, but that requires some very specialized programming, because it's actually computing maximum likelihood estimates of the underlying dimension question by question. So that's, here at the DCRI, our programming team would not be able to do that without some help.
Yeah, the reason I was bringing that up is that I certainly have not seen disclosures to Northwestern as part of that would be required if you're using their software, their site.
We have gone through this with our consents. So this issue has come up, and we'll look forward to an engaging offline discussion that hopefully won't get us in trouble. Yeah.
I would just imagine that for the groups that you mentioned, that the responses would be quite different, meaning for the given feeling, that some of the scoring would be different in someone that had heart failure or had cancer and so forth. Is that what you see?
With respect to sexual function, Rick, or
yeah. I mean, let's say that they were on the same level of the same scale. I would just imagine that a bad day for someone with heart failure is quite different from a bad day for someone that is being treated for malignancy and for diabetes.
Well, right now, the comparative data we have are more qualitative, and we're going to be doing the more quantitative comparisons there. But I we'd agree with that.
So it seemed to me that depression is blamed for everything. And there, too, it's hard to believe that if you put everyone on an antidepressant, that all these things go away. So what are you finding is kind of at the heart of some of these responses? Got to be more than depression.
You want to? Well, first of all, I'm not sure people in the field of sexual health would ever claim that depression is the main reason why people are having problems.
Just everyone else.
Just I think certainly the patients we've talked to have mentioned depression. There's a lot of comorbid depression with some of these chronic diseases. There's depression that results from and exacerbates some of the sexual function limitations. But there are a lot of very specific disease-related things that interfere with their functioning. They've got pain from some injury or post-op. They've got a shunt in place or something that makes things awkward, and so those are the things we've really been trying to learn a lot about. What are some of these symptoms or side effects of specific diseases that are interfering?
I'm running out of material here. Come on. last question. In the long run, what would the NIH like? I mean, they've come to you, and obviously to other centers. They put support behind this. Well, what do you think is the end result that they're looking for? What would they like to learn? What would they like to do with this information?
I think that they very clearly would like to consolidate they'd like to make a repository of the best ways to measure concepts that are relevant across chronic diseases. So there are a lot of other NIH-funded measurement initiatives. The NIH Toolbox is for neurocognitive deficits. They're trying to harmonize all of this. They think that that's going to help streamline research by doing that. So that is their hope.
That's great. If there are no further questions, I'd like to congratulate you on your work. We look forward to having you back as the data come forward, and thank you for your time.
Thank you.